So I go to a cardiologist every 6 months and he spends 3 minutes with me and they've done an EKG. He looks at the report. He says, your EKG is fine. See you in 6 months. When our AI was first being prototyped and I tested it, put the device on my chest and it said I had a murmur. I thought, how can I have a murmur? I've literally just come back from my doctor. And he says, I'm fine. But of course, an EKG doesn't tell you if you've got a murmur.
Stephen, thanks so much for joining the podcast today. I'm really excited to speak to you today, hear more about your work at Medaica. And first off, can you tell us and the audience, what is Medaica and what sparked your idea to tackle like home diagnostics and like these self-exams for both heart and lung health?
Well, Medaica is a medical intelligence company and it's all about detecting heart and lung disease early and acting early. What sparked the idea were kind of two intersecting problems and issues. My background, I'm a platform guy, a sort of philosophy where a lot of the markets that I've been involved with often fragmented, siloed, and you look at, say, the mobile industry, which is one example that I've been in. There was a time when you could text message on AT&T, but that text message couldn't go to Verizon.
Yeah,
and I was looking at the healthcare market and thinking it's exactly the same. You could have a medical record in one system that wouldn't translate to another system, a device that would work on one system that wouldn't work on another. And in time, this just doesn't scale. So, obviously, famously, the healthcare industry is pretty broken. And as an civil entrepreneur, I wanted to attack that. I also have a history of heart disease in my family, so I was very interested in that. And actually, 80% of heart disease is addressable, is avoidable. And to me, that's just a crime. It shouldn't be the case.
Yeah.
And screening for heart disease and lung disease is not scalable. It's completely broken. And obviously, with technology, with AI, that can be addressed. So all of those things together led us to founding the company. We had some experience with high-end devices that were being targeted at doctors. And again, these would work with a specific proprietary solution. I was looking at a particular scenario where if you have a stethoscope that's got AI and it could detect, for example, COPD, but a doctor wants to examine a patient that might have heart disease or might have asthma or something else, they may have to use a different stethoscope and different AI. So, eventually they're going to use 10 different stethoscopes for 10 different conditions. It's a ridiculous situation.
Yeah.
And it reminded me of my Symbian days with one phone that would be incompatible with another network. So all of those things together collided into the formation of Medaica.
Interesting. That's fascinating. And like you, I relate to the heart disease in the family. My father had a heart attack unexpectedly, that could have been avoidable had he done sufficient diagnostic tests up front, So
I have two experiences that I'll relate to you in a couple of minutes, but it's the first one was that I was experiencing some chest pains in America and had a cardiologist look at me, did a stress test, and he said, yeah, everything's fine. You're good. I happened to go to the UK. You can probably tell that I live in America, but my background's in London. So I was lucky enough to go to my UK doctor. And he was more curious and he did scans and he said, actually, you have an artery that's 95% blocked.
Yeah.
So I might have died just because the healthcare that I got in the US was just not curious enough, adequate enough, motivated enough to do the right tests.
Yeah.
So that's my first brush with it. My second brush is later in the evolution of Medaica, which is a more interesting story, which I can probably mention later when we talk about tech.
Yeah, spot on. No, it's amazing the amount of Americans that probably don't know they have like arteries blocked because of lack of diagnostic testing or upfront. Because you really only you go to your cardiologist when a problem presents, right? Or
it's reactive right now.
It's very reactive. Yeah. And lung is another area we'll have to touch on, but in terms of the tech, I'd love to dive into that. Like you've built, and scale platforms most of your career. It sounds like across not just healthcare but consumer technology.
Yep.
What's been like uniquely challenging about building like a digital health company, and like what lessons are you pulling from both worlds, from your prior like consumer background? What are you bringing into the tech that you're building into healthcare?
Well, the war wounds carry forward. So the stethoscope was invented 200 years ago, and doctors for a very long time were listening to things like if your heart valve doesn't close properly, it causes turbulent flow, and they can listen to that. They can hear heartbeats, the lub-dub sounds. And so if it's a regular lub-dub, 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 they can say, okay, you don't have an arrhythmia.
Right.
But a lot of that training has been lost over the years. But it's actually it's a very good diagnostic tool. So if you could use AI with those sounds, what you have is a very, very simple triage tool. And not only that, if you can do that remotely, if you can connect that over the cloud, you could actually have a tool that for a consumer will tell them if they're having, some kind of heart problem.
Yeah.
And so we just wanted to democratize that process. And a bit like hearing aids, hearing aids for a long time were $2,000, professional ones, and no reason. You can get earbuds for $15. But digital stethoscopes are typically $400, $500. There's no reason for them to be that price. What if they could be the same price as a blood pressure cuff? Then you could have a device like this in every home, so that a mother could listen to a child that's maybe got asthma, or a child could listen to a parent that maybe is having heart problems, and get an indication that this is a normal or abnormal sound, and then know whether they need to go to ER or know whether they need to follow up with the doctor. So there's that normal sort of early warning sign or triage tool that just doesn't exist, and it should be something that's inexpensive and easy to use remotely, and plug and play with any kind of telehealth system. So all of those problems of technology and compatibility and cost hadn't been addressed.
Right. Yeah, spot on. And I know you gave the example of digital stethoscopes, but before we get deeper into the tech, like what other types of like diagnostics tools are available or are soon to be available in the home for like heart and lung health? Because I'm just thinking about my own father, and he like gets like routine stress tests, because he's a cardiology patient, but that requires going to a facility. And at the home, like, is digital stethoscopes are one option. Is that the main type of tool being used in the home, or
what else is being? It's too early to say it's the main tool being used in the home. We're at a very early stage in our evolution. At the moment, you've got devices like EKGs, like the Cardia Alive Core device, which is very popular. Yeah. You've got obviously blood pressure cuffs, pulse oximeters. But, even with remote patient monitoring, a lot of the tools used are basically scales to see whether you've put on weight if there's fluid around the lungs. Pulse oximeters is and blood pressure cuffs. It's very, very primitive. They're not even that accurate. So that the accuracy is going to change over time. But if you could add a stethoscope to that mix and EKG as well, you've got pretty much a whole diagnostic suite of tools that can give you a lot of insight before you go to ER or a doctor. And to get to get into the doctor, it can often take you weeks or months. So, and sometimes the symptoms don't necessarily present themselves when you're in front of the doctor. So having those tools at home, we think is going to be table stakes for most people.
Oh, 100%. Yeah. And because, a lot of those like remote patient monitoring devices have been around for a while now in the market, but having access to EKGs and digital stethoscopes at home, like that's the next frontier, how do we bring these things that can easily be done from the comfort of a patient's home, and they don't have to either travel to their facility. Sometimes, mind you, some patients are in rural areas. They can't even travel to their, doctor.
That's a massive problem. Yeah. And related to that is a problem that very few companies have thought about or know about. And so, okay, you've got a patient saying, in a rural setting, and they've got a device, and now they want to speak to a doctor. Can the doctor get that data over telehealth? And at the moment, telehealth is primarily something like this. It's just audio and video. It isn't really data at the same time. So we've spent a lot of time in designing our IP that the channel for the data can go through this, what we call Telehealth 2.0. So you can plug a device into, say, Zoom, and the doctor can then auscultate you remotely. And how do you do that? How does a doctor guide the patient, listen to the patient, record it in lossless audio, even if it's a poor connection? So all of those problems we've solved.
That's fascinating. And that's a big problem, because a lot of providers have adopted telehealth coming out of COVID, even during and post COVID. So the ability to integrate data into those appointments from devices and, diagnostic tools at home, that's huge. And I know you guys are also working on like FDA-cleared, the like low cost sensors that are paired with AI. What are you building in that? And what are some of the, most promising use cases you're seeing?
Yeah, good question. So we already have an FDA-cleared sensor and auscultation platform that is about a tenth of the cost of competing professional platforms. So it's almost to the point where you could give the sensor away to the patient, because the sensor isn't, we're not a hardware company. At the end of the day, we're an AI platform company, medical intelligence. So it's really about getting the price of the hardware down. The hardware there isn't magic in the hardware. The magic is in how you interface that with existing systems. So a lot of the intelligence can be in the cloud, so you get the price of the hardware down to a minimum. And then the intelligence piece is the AI. How you denoise the signal and then apply AI to extract the features.
That makes sense. What type of like traction are you guys getting in the real world with these sensors and AI? Have there been examples of, them being used in patients' home? If not, have you guys tested that out? What does the initial like read look like?
Well, yeah. So actually, I want to give a personal story and then directly address your question on the traction. So when our AI was first tested, I mentioned a proud owner of 2 stents, actually. So history of heart disease in my family. So I go to a cardiologist every 6 months, and he spends 3 minutes with me, and they've done an EKG. He looks at the report. He says, your EKG is fine. See you in 6 months. So as far as I'm concerned, as a mere patient, that's great news. When our AI was first being prototyped and I tested it, put the device on my chest, and it said I had a murmur. And I thought, how can I have a murmur? I've literally just come back from my doctor. And he says, I'm fine. But of course, an EKG doesn't tell you if you've got a murmur. It may tell you you've got an arrhythmia or other conditions, but it doesn't mention a murmur. So I went to one of our clinical advisors and said, listen to this signal and tell me what you hear. And he said, I can hear a murmur. The AI is confirming it, the clinical advisors. So I booked an appointment to go back to my cardiologist, who, by the way, I should say is now my ex-cardiologist.
Okay.
And I said, I have a murmur. His knee-jerk reaction was, why are you telling me you have a murmur? I'm telling you you're fine. And so I told him what we were developing. And so for the first time, he listened to me with a stethoscope and he said, oh, Stephen, you've got a murmur. We need to get an echo. So I got an echo, confirmed the murmur. And actually, I have very, very early aortic stenosis. So that's kind of the on-ramp to maybe in 3 years, 5 years, I might have valvular heart disease. It's asymptomatic. Most people would never know that they've got that. There's 800,000 undetected cases of valvular heart disease in the US every year. And a lot of people just die. They don't know anything about it. We don't have the equivalent of an engine warning light that says, if you don't go to the doctor, you will have a problem. We just are reactive. Yeah. So we are working with organizations to test for early signs of valvular heart disease. We're also working with hospitals like Emory on rural, because the confluence of number of rural patients that don't have access to a doctor, they're more than an hour away from a doctor, is a major problem in the US.
Yep.
And we're also focusing on what I call 65, 25, 10. So this silver tsunami is here. That's that there's more people in America over 65 coming into the population from now for the next 3 years, more than ever before. And anybody over 65 has 25% chance of having a cardiovascular event in the next 10 years. Yep. So we want to focus on those. But again, we're a startup, we're just starting. So we're working with organizations, just started with, say, with the VA. About 30% of the VA is in rural areas, working with hospitals that have a big rural problem and focusing on those patients that are over 65.
Yeah, it's no joke. I've been preaching that for a while. You called it the silver tsunami, or some people call it the baby boomer generation. They're all going to retire, including my father. He's in that age group, and they're coming into the market. And not only is that gonna crank up the amount of people in the Medicare program, for those that are eligible, and then also, like you said, unfortunately, the risk of cardiovascular disease and other diseases goes up, with this population. And that story you told, by the way, I want to go back to that for a second, is extremely powerful and crazy to hear that you had this murmur and your AI, when it was first being prototyped and the device on the chest was able to pick up the murmur, and then you went back to your doctor. I mean, just think about the amount of patients, similar types of patients in your shoes that don't have access to those devices, and go with undetected diagnoses for so long. And like you said, there's no warning light. This isn't like your body is not a car vehicle that'll turn on a warning light when something's going on. You need to have access to this technology that can tell you that, right? So very
And
powerful.
in primary care, the skill set is almost forgotten. That a doctor might have been trained 10, 15, 20, 30 years ago. Their hearing may be going. How many doctors actually use the stethoscope with their patients? They're very rushed and they don't do that. But there's technologies today where they can put a stethoscope on you. The stethoscope will guide the doctor that there is a murmur or an arrhythmia or other problems. And then when they refer to a cardiologist, maybe 80% of the patients actually do need a cardiologist instead of the other way around. My cardiologist's reaction was, "Are you going to put me out of business?" And I said, I think on the contrary, imagine 80% of your patients actually needing a valve or stents instead of not. They're going to be more valuable. And so he joked, "Oh, I'm going to get a bigger boat." But unfortunately, again, part of the healthcare system is to do with monetization more than outcomes. And it's back to front. We know that.
No, and I mean it's the reality of there's a camp of like, hey, yeah, is this AI, is this technology going to replace my job? But there's other camp, which is probably the more correct camp, is like, this is going to enable you and make your job easier and better. Like, it's literally like we're early risk detection and early diagnosis is only going to become more prevalent and as technology advances. So it's either like you adopt it now or you adopt it 5 years from now, 10 years from now, when all your peers are already on board, like.
Yeah, well, look, the cliche is that AI is not going to replace the doctor, but a doctor with AI might replace a doctor without AI.
Yeah, absolutely. Yeah, and we did a podcast not too long ago with a doctor who's very pro AI, and he's like, look, if I had a device that he works in the ED that could tell me information on the patient before they even come in, like environmental information, what happened to them before, like longitudinal data, like,
yes, exactly,
like
perfect.
that would make my job even easier and more effective, So you do have certain doctors out there that are in favor of it, but
Well, I thoroughly recommend all the books by Dr. Eric Topol.
Eric Topol.
He wrote The Patient Will See You Now and Deep Medicine. His vision of the future is exactly aligned with ours. And it's going to be the patient being proactive in their own health. Yeah. I know a lot of the old-fashioned doctors will say that, well, you're coming to me with Dr. Google, I'm the doctor. But actually, all of that information is valuable. So, if you're coming, say, with information from your Apple Watch or from a cardia EKG or from a Medaica stethoscope, that is useful to feed into the diagnostic process, the screening process.
Yeah, right on. I'll have to check out Eric's books. I've read a lot of books in the healthcare and healthcare innovation space, but that's one I'm going to have to add to my reading list.
Thoroughly recommended.
And so what are like, Stephen, some of the biggest hurdles you guys have faced? And like, we're both in favor of this technology, but what are some of the hurdles you guys have faced in gaining, buy-in from clinicians, maybe regulatory bodies, commercial bodies, because you guys do have products you're working with, like physical products. Yeah. What are some of the biggest hurdles you guys have faced with those groups, and what's helping you move past them?
Well, I think there's hurdles at every stage in the value chain. You can have a doctor that's very excited about the technology, but maybe it's got to be the IT people or the admin people that buy into it. And I always say you've got to basically be selling a fire extinguisher to somebody whose hair's on fire. So if their hair isn't on fire, it's a nice idea, but maybe that's not what they need right now. Yeah. So you've really got to go to the people whose problem it is. And I think that, today the problem is that hospitals or the insurers that are thinking about the cost structure of dealing with people who are over 65 that are rural, that there's wider use cases than that. But the clinics are overburdened. The patients are often going undiagnosed, so they come into the system later where it's more expensive. They're getting more expensive tests that are not needed. So from a payer's perspective, if you could triage that patient with a Medaica test that would be, let's say, $10, $50, under $100 versus a test that's going to cost you $500, $1,000, $2,000, then it might make sense instead of referring a patient for an EKG or an MRI or anything else, X-rays and more expensive tests. There's going to be lower cost test. So this has to make sense to the economics of the equation, or unburdening the clinic.
Yeah.
The other part of the value chain, which is challenging, but also where it starts to make sense, is there's a lot of video platforms out there that are pretty much commoditized. So you asked about the sort of challenges that we meet, but it's part of it is the hype cycle. So as you mentioned, after COVID, although we're in big scare of COVID, a lot of the panic around telehealth and implementing telehealth dropped.
Right.
So, but telehealth is here to stay. So how do you make telehealth something where you can actually have a meaningful exam? If you could do a wellness exam, if you could auscultate a patient, get an EKG and get all of the data that doesn't require them coming into the clinic, and you can de-skill that so that an assistant can acquire that data,
Right.
you're going to have a much more efficient system. So we believe that telehealth over the next 2 to 5 years is going to be much more enabled with devices. So there's going to be a digital data channel that flows through the same channels as audio and video.
Yeah.
So the challenge is the hair on fire at the telehealth companies that need to not be commoditized, is the hair on fire at the payers who are spending too much money on more expensive tests that didn't need to be done. And I think the answer is the hair is smoldering at the moment. It may not quite be on fire, but it's smoldering.
Yeah, no, spot on. I mean, everyone plays a role, right? It has to make sense for the economics of, like, whether you like it or not, of like all the groups in the pictures. You know, the patients don't want to pay for expensive exams or have to travel to pay for an expensive MRI. If they have options to do it at home, if there's an alternative, like, odds are they'll buy into that. The payers are incentivized to maintain the health of their population and not drive up costs, you know? And I know there's a big push when you raise the telehealth with reimbursing telehealth in the market.
Yeah.
Like, there has been some advancements in that. Mind you, it's not perfect yet, of course, but there are pockets of areas where providers can get reimbursed for telehealth through different code sets. So,
or in cases, patients will pay for the answer themselves. You know, if I've got a child that's coughing and wheezing, is it an emergency? Is it a panic attack? What do I need to do?
yeah,
And if that's going to cost me $25 or $50 rather than waiting 3 or 4 days,
rather than waiting, that's the key.
Or go to an ER and suddenly I've got a bill for $1,000.
Yep, exactly. Spot on. Hear you on, some of these hurdles at every step of the value chain, but everyone plays a role. And, at the end of the day, this helps your patients, right? Like, that's the message. Like, when it's done correctly, when there's buy-in, at the end of the day, it's going to help your patients. And stories like yourself of, hey, I had a murmur that my cardiologist had no idea about. God forbid other folks have, also clogged arteries that don't know about it. I'm sure there's
it's way too common.
Yeah,
and the sad and sobering thing is that when we started the business, we thought that this is going to be a third world country opportunity first. And then we realized we're actually having a lot of the same problems in America. There's 50 million Americans that don't have access to healthcare. And so, we've got a major problem here that we need to sort out.
Yeah, 100%. And it's going to take, I think, everyone's participation to solve it. Better technology, better access to care, lower costs, like better quality. Like, I had an old professor, Ezekiel Manuel. He put it nicely. There's the iron triangle of healthcare, right? It's cost, quality, and outcomes, and all those three have to come together for the system to work efficiently.
Yeah, spot on. Yeah.
So what is next for Medaica? I know you also have a co-founder, Pablo. Like, what's next for you and Pablo, and how can potential collaborators or other, clinician partners, whether they're design partners or actual like users of the tech, how can they engage with you and your team?
Well, actually, I'm glad you mentioned collaborators. So this is something that I don't believe any single company can do on their own. A little bit in the weeds, but technically what we collect with our device are called acoustic biomarkers, and they're pretty valuable. This is what doctors have been listening to for 200 years, and AI has been listening to for about 15. But it's a fairly new corner of technology. There's only a few thousand acoustic biomarker samples in the market for researchers to work on. And one of the things we want to do is create what we're calling 1 billion heartbeats and breaths, a database of 1 billion heartbeats and breaths, so that researchers can accelerate research into conditions using AI. So if partners are interested in collaborating with us, just contact us via our website or via my email. I'm Stephen.Randall@Medaica.com, Stephen with a PH. and or contact me through LinkedIn. No one company is going to have all the algorithms for all of the conditions, and this is rapidly changing on a week-to-week basis. So we'd love to work with researchers, with hospitals, with payers, with doing pilots. And the other thing is how this is actually used, following customer through the workflow, so that it's not in the end about selling technology, it's about selling a solution. So how is the solution actually going to get implemented into the work environment? Because whether it's a nurse using it in a hospital and a patient going home with a device, whether it's the device being bought by a patient, and then how do you connect to the doctor and how do you use it over telehealth? Is it a plug and play with a telehealth? Do they have to use a different system? I could answer all those questions, but it may be different for each customer we deal with. It's really the solution, not the technology, that really needs to be worked on, so that you have something that is for the patient plug and play and minimally distracting for the doctor, because we know that they, if they're going to spend even a few seconds having to learn something. I'll give you another example. A lot of devices today are Bluetooth, or they work on cell phones. Bluetooth, I was involved in implementing that as a standard at Symbian. It's wonderful technology, but it's not always great in a clinical environment. Lots of interference. If your battery hasn't charged up, you can't pair. And if you're using it with a phone and you suddenly get a phone call, it's not a very professional way to do that. So there's a million and one actual implementation problems. So if you just throw technology over the fence, you're not going to have a successful use case. So we have an expression that we will walk over broken glass for our partners. So we're still in that process.
Yeah, that's lovely. And I love this mission of collecting 1 billion heartbeats and breaths. It speaks to your guys' vision as a company, and like you said, it's selling the solution, not just the technology, right? And clinicians, I think the worst thing is they're so swamped with the work they have to do. Like you said, when you met with your cardiologist, he had 3 minutes, I think you said, right, to meet with you. So
barely.
Barely. Yeah. If you make data collection or using AI a complicated process for them, like the buy-in is going to be more difficult.
You can spend more than 3 minutes getting your Bluetooth to pair.
That's true. Yeah. Sometimes true. But no, Stephen, it's been wonderful having you on the podcast today. It was a pleasure speaking to you, and definitely going to keep tabs on your journey and Medaica's journey. And I'm excited to see what's next for you guys with different clinician partners, the work you guys are doing with other hospitals, health systems like AMCs, like you name dropped Emory earlier. So excited to see where you guys go in this direction of heart and lung health, which are two very important areas. And like you said, the boomer generation, or the silver tsunami, as you call it, is coming, and
Absolutely.
We need better access to technology for our seniors.
Well, pleasure talking to you. Thank you very much for allowing me on your podcast.
Likewise. And it was awesome speaking to you today, and thanks for being a great guest.